One second, Jennifer. All right.
Oh, good morning. I do want to apologize that my image is a little dark based on the lighting in my office. It varies, so I do apologize for that. And there's nothing I've been able to do to get it to work. On sunny days, it's better, which it is sort of sunny out, so I'm not sure why it's looking like that. I also just want to, for a disclaimer, I'm so used to doing presentations and trainings in person. So this is a new challenge for me. So though we have been living in the Zoom world, I'm a much more in-person presenter and trainer. So please bear with me. I also know it's such a large group in a lot of different backgrounds and roles. So was really trying to navigate what would be the most helpful during this time together. So we did decide to skip past some of my slides to jump right into, some of the common disorders that you might come across, and also kind of what to look for, and then to talk a little bit more about our services. And while we do that, we can have open conversation if questions come up about the services or just what you're, engaging different symptoms or behaviors or how to get mobile involved or how to get different services involved. I'd rather do it that way to make sure that I meet the needs of what everybody's looking for, as opposed to just droning on and reading a bunch of slides to you. Because I mean, we can all look at slides all day long, but I'd rather it be interactive and really be able to answer your questions. So just jumping right to common disorders, you are probably facing or experiencing individuals that have ADD, ADHD and ODD, disruptive mood dysregulation disorder, anxiety disorders, PTSD, developmental disorders, bipolar disorder, depression, eating disorders, psychotic disorders, and substance use disorders. And in the next slide, we'll just go through a little bit of, some of the symptoms to be aware of. Again, probably things you're already experiencing or working with, but I just wanted to make sure that we talked a little bit about some of the symptoms and behaviors for each diagnosis. Somebody experiencing depression, that looks different for everybody. A lot of times people think about depression and just think about sadness or hopelessness, but also there is guilt and helplessness. A lot of times in adolescence, we see irritability and anger and aggression, especially even in younger kids. So it's something to really keep in mind that with depression, it's not just straightforward about sadness or somebody not wanting to get out of bed. It can look like anger and irritability and aggression. Sleeping patterns or eating patterns can be disrupted with somebody being depressed. Suicidal thoughts or gestures. Now, that doesn't necessarily mean that everybody that is depressed has suicidal thoughts or gestures, but it is definitely something to be concerned with somebody that is experiencing depression. Loss of interest in normal activities. It's really important. One of the things that I do when I'm interviewing a client, whether it be at mobile or when I work at the hospital or just in my history, it's really important to find out what there are things that they do like to do, and then find out if they've kind of stopped doing those activities, because that is a red alert to me that if they are not doing things that they enjoy, that means they're not even having the energy to do things that they like. And that kind of speaks to me, their level of depression and maybe a higher concern for, potential suicidality. Poor concentration and inability to focus. Obviously, you may see that in ADHD or ADD, but that is also something that somebody with depression does struggle with. PTSD is obviously a reaction to trauma. You might see hypervigilance, flashbacks, nightmares, avoiding triggers. One of the things that I like to talk about when we're talking about somebody that has trauma is really being aware of that a trigger is different for everybody. That could be sounds, that could be somebody's voice, thoughts, smells, places, something in the media, feelings or situations. So it's just, really important to be aware that triggers are not always something we can see. It might be something, I'm jumping all over, Bree, just bear with me. You can stay right on this slide. I'm just jumping back a little bit to speak to the PTSD piece. So trauma is not something we can necessarily always see, and they may not always be able to articulate, what their triggers are. One of the things that, we talk about for trauma is not all scars are visible. And so we just need to really be aware of that when we're managing somebody that has trauma. And really at this point, which I know all of you know this, really the message is that we should go into every interaction or situation understanding that trauma is universal, and probably every one of us or any client we are working with, or youth, or an individual that they are probably experiencing some type of trauma. I mean, just alone with us all experiencing COVID, we've had some type of trauma. So it really is just important to kind of go in assuming that everybody's had some type of trauma, and understand that there may be triggers involved. With anxiety, again, very similar to PTSD, there's hypervigilance, excessive worry, restlessness, rapid heartbeat, trouble breathing, sweating, and shaking. So somebody that's obviously having a panic disorder, might actually feel like they're actually having a true heart attack. And so sometimes that's hard to identify whether it is just anxiety or a heart attack. So, sometimes folks will call 911, or, staff at a group home or in a shelter will call 911 because the individual might actually truly feel like they're having a heart attack, because the feeling is real to them, but it may end up only being a panic attack or some anxiety. So just things to be aware of. Bipolar disorder is a fluctuation of moods. Individuals can go from a manic or depressive state. Some folks stay completely in a depressive state after one manic episode. If you're seeing somebody that has little sleep or no sleep, pressured speech, risky behaviors, easily distracted, and grandiose ideas, they may be suffering from bipolar disorder. Psychotic disorders, most common that we hear about is schizophrenia. But individuals that have psychotic disorders can have delusions, false beliefs. They might believe somebody's tapping into their phone systems or their TVs or tracking them, have hallucinations potentially, which could, either be hearing things, seeing things, smelling, tasting, or touching. Sometimes that gets tricky with some of the substances that individuals are using. So we have to really kind of, assess, whether there is substance involved. Disorganized thoughts and speech, and flat emotion. Somebody with schizophrenia can also be very flat and have depression. The most important piece for me for psychotic disorders or an individual that's hearing voices is command hallucinations. When I do a lot of trainings with police, and anybody that is going to be working with individuals that have a psychotic disorder and or somebody that might have bipolar disorder, that if they become manic and they have lack of sleep, can end up experiencing a psychotic component. It is very, very important to be very clear and ask if somebody is hearing voices, and if they're command in nature. Individuals can live with voices all day long, as long as the voices are not telling them to hurt themselves or anybody else. But it's very, very important to ask if the hallucinations are command in nature, because that can really put somebody at extremely high risk to themselves or others if they are experiencing command hallucinations. So that is something I, really stress in the police academy, that, they might get called for a wellness check for somebody that's, acting, strangely in the park, and the individuals maybe not saying they're suicidal, homicidal, because the police are trained to ask that very simple question. That they also need to take it a step further and ask, especially if they see that somebody might be experiencing auditory hallucinations or saying they are, asking that question so that they don't drive away and not have asked that question and then have the person act on their hallucinations. Before we kind of jump to the next slide. Does anybody have any questions about that? Now, understand that these are just some identifiers. That doesn't mean that everybody with depression has all the bullets. Not everybody with psychotic disorder has all the bullets. It's just things to be aware of and to kind of have a better understanding so that you can support the individuals you're working with. I guess we can go to the next slide. I'm going to defer to you, Bree, and if there are questions or.
That sounds great. I'll let you know if I see.
Okay.
Yeah. Thanks so much.
Just because I want to make sure I'm not missing somebody.
Absolutely.
So, okay. So different levels of care that are available, not only for Northern Rivers, but just in the community in general. You know, really from a continuum of care perspective, really the idea, and New York State is actually, you know, really putting a lot of focus and services into crisis services. They're actually planning and hopeful in the next 3 years. I think it might take a little bit longer than that because I think initially we didn't plan on COVID causing some havoc in some of our lives, but the plan is long-term for New York State to pretty much have every county. They want to have a mobile crisis team because not all counties have it. And ideally have it be 24/7. And the reason for that is a lot of individuals get sent to the ERs or hospitals with sometimes a misunderstanding of what an ER or a crisis unit or a hospital can do for an individual. Really treatment and care for somebody struggling with mental health or just an emotional behavioral crisis is really something that mobile crisis or an outpatient setting should be managing. An inpatient level of care, there are so many layers legally to even get somebody to that level of care. And they have to meet certain criteria. It is basically taking somebody's rights away. So we take that very seriously at mobile, which is why sometimes we do a lot of safety planning. And I know that that's sometimes frustrating for the community because sometimes there are this belief that people need to go to the hospital. But that's, I find sometimes is because not everybody understands the hospital system and what the hospital can actually offer. Just talking about Albany Med as an example, they have a pediatric unit. And when they opened up their doors 5 years ago or around that time, I was positive they were going to get inundated with youth across, you know, the capital region and all the way down south with this idea that if they have 57 specialties on their sign, then they must have psychiatry. That is actually not accurate. It is not a specialty in the ER. It's only something that they have started to slowly transition into the ER because of the need. But it is not, the ER was never meant to have psychiatry as a specialty because it is a trauma hospital. It's meant for medical and emergency medical needs, not a psychiatric or behavioral health. But they do have some services. When individuals come to the ERs, especially at Albany Med, they don't have like a crisis unit. So they are just in the ER. There's no psychiatrist there or groups or treatment going on. And so we really want to make sure that we're not sending somebody to the hospital unless they really do need that level of care for a couple of different reasons. One, it can be an extremely traumatic experience for individuals sitting in the ER or waiting to be seen for hours and hours, and sometimes even potentially days that they're just sitting there before they're actually getting any evaluation, let alone treatment. But then even if they get evaluated now after a couple hours, 20 hours, they might still get discharged and not necessarily get connected to services or treatment. Whereas a mobile has the capacity to do follow-up after an evaluation and keeping somebody in the community, getting them connected to services, and also working with outpatient providers that might already be involved. Of course, if somebody needs to go to the hospital, then we facilitate that. There are actually individuals that we send to the hospital that still get discharged. We have a very good idea of what we feel needs to go to the hospital and also what a hospital might keep. But believe it or not, even though we do this every day, all day long, there are individuals that still get discharged even after we have done our own evaluation. Just to give you an idea of what our evaluation looks like, we're doing like a full evaluation. It actually sometimes probably is more extensive than the ER evaluation or the evaluation that might happen at a crisis unit, because we're really looking at start to finish and looking at what that individual needs, not just to assess safety and walk away. Like, we want to make sure that we can keep them safe, that they have the resources they need, and work on helping them get connected. The ERs are getting inundated right now with so many folks going to the ERs, whether it be sent by schools or law enforcement or primary care doctor offices. Instead of calling mobile crisis, which the state is really asking individuals to try to start at that level of care and let us help decide whether somebody goes to the hospital. Because what is happening is the ERs are on diversion regularly now, which means, you know, if somebody goes to the hospital, they may get turned away, or the police are driving. Sometimes police in Troy are driving all the way up to Glens Falls just to bring somebody for a behavioral health assessment, because all the other hospitals have no more bed availability. And those beds are being taken up by individuals that maybe never actually needed to go to the ER, but now that they're there, they're stuck there until they get released from a doctor. And so just some things to think from a systems perspective, that's why there is a continuum of care, why there's different levels of care. They are most ideal if somebody is in crisis would just be to start with a crisis service and then work with outpatient level of care after the crisis has been diverted. And then if not, go to the hospital ER and then inpatient if need be. But just because somebody goes to the hospital doesn't mean they also automatically go inpatient. Many times individuals in the moment, even if we're talking about somebody that may be suicidal, in that moment they're suicidal, but suicidality is very fleeting. It comes in waves. And so that person might say to you they're suicidal, and by the time they get to the ER and by the time they're seen by the ER doctor, they're no longer suicidal, which is why so many people get frustrated when they send somebody to the hospital and those individuals or youth are getting discharged, because in the minute of the evaluation, by the time they get evaluated, they're no longer feeling the way they were when you interfaced with them. And then they don't meet the criteria for hospitalization or to keep them against their will. And so just keep that in mind as well, which is, you know, why, again, we would like to support all of you, you know, in decision making on, so that there isn't that frustration. We hear from law enforcement all the time that they drive somebody to the ER and before they've even driven out of the parking lot, they're already being discharged. And that's because by the time they drove them to the hospital, they no longer were feeling the way they were feeling. Many times people are just talking and expressing how they're feeling, but also there are individuals that live with suicidality every day, all day long, that don't necessarily need to go to the hospital. And that's not necessarily your job to help decide that, which is why we ask you to call us. You know, if there's intent or plan or no protective factors, those are all the things that we look at when we're assessing somebody. We leave people in the community all the time that are suicidal, and a lot of people don't understand that, but that's because people have the right to be suicidal. It's whether or not they're going to act on it, or they have intent or plan or actually means. And we would rather work with somebody that might be having those feelings and keep them safe in the community, rather than have them have a bad experience with the system, and then the next time not actually call for help. So that's why we do what we do. We, back in 2018, again, not necessarily knowing all the folks on this call, because one of the things that I hear a lot from coming to mobile, for being with mobile for 5 years and coming from the hospital full time, there is back prior to me coming, which was in 2018, the only way to access us was through gatekeepers. So if you were in Albany County, you would have to call CDPC to get to us. If you're in Saratoga, you'd have to go to through Saratoga Hospital or Saratoga Mental Health. Up in Glens Falls, it was through Warren and Washington County Commissioner's Office or Glens Falls Hospital. So a lot of people think we're like this new service, especially up north, or just in general, but we're really not. We've been in the capital region for kids for almost 17 years, and for adults and kids up north, which would be Saratoga, Warren, and Washington, we have been a program and a resource to the community for almost 8 years. We only in 2018 went to our own crisis line. So we became our own like mini dispatch system. And so basically anybody within our operating hours, which there is a slide down below, but it's Monday through Friday, 7 to 11 and Saturday, 11 to 7. Anytime they call, you're going to get a crisis worker. Most often it's a licensed clinician that are screening the calls and deciding whether or not that they can provide support over the phone, because we have a lot of folks that just call us directly, like a 988, that just need to talk. And so we do provide that support, or we're doing assessments to decide whether or not we can provide them that assessment and that safety planning over the phone. And the more higher risk calls, based on our triage and information we extract from the folks that are calling us, we will send a team out. We really are put in place. We're county and state funded, and it's to avoid unnecessary hospitalizations. 2 years ago, we became Medicaid billable. That only means that to help grow our program and continue to work towards going 24/7, it's extra funding for us for anybody that might have Medicaid that we can bill. The service is absolutely a free service. Nobody gets charged or billed, no matter what insurance you have or if you have no insurance. So please don't be mistaken that you have to have Medicaid to use our service. We are an absolutely free service to anybody and everybody within our 6 counties. And it's just that if you have Medicaid, we can bill to bring in more funding to help grow our teams. The idea is that we would have already been 24/7, but COVID created some havoc on our lives like everybody else's. Workforce crisis has been challenging, but we are continuing to still work towards that. That's why we're not fully 24/7 yet. And the assessments that are completed, if we are doing a full assessment on deciding whether somebody stays in the community or needs to go to the hospital, those are done by licensed clinicians, either LMSWs or LMHCs. In the conversations, we, like I said, can provide telephone support, consultation, information, and then we do connection and referrals. We have case managers on our staff that will connect to health homes. We'll coordinate with current providers. We always do next day follow-up as long as the client has not told us they don't want us to make sure the safety plan is working or if we need to go back out. We also, on our team, we have our clinical side, but we also have our support side in regards to, we have peer support specialists on our team, which are individuals that have lived experience. And we also have family advocates that work with families to really help navigate the system, but also provide support from a peer perspective, and also just understanding of raising, adolescents or youth or family members with mental health or disabilities, or somebody that has that experience with their own mental health and how they have continued to support themselves through that. That's our team composition. I think I'm kind of jumping all over, Bria. I apologize.
No, this is great. I am curious if we want to pause here for a second though, and
Sure.
ask anyone within, on the call, if they have any questions about getting a hold of, mobile crisis or anything like that. If people have had, I know, positive experiences in the past of being able to access services, but if anyone has any questions about the access or the system of care, I think this is a great time to pop your questions in.
Yeah, and I also would just say, well, let's just jump to slide 15 while that's happening, just to give folks an idea of what to call us for.
Perfect.
I want to make sure that everybody really understands that we are not just meant to be called, like if somebody's suicidal or homicidal. Our program is for emotional and behavioral disturbance, agitation, psychosis. We work really, really closely with law enforcement. They call us, but then also we, for example, in Schenectady County, are built right into the 911 system to actually try to decrease police response for calls that we can manage. And that comes from the crisis intervention training from the state on the police side of things, law enforcement side, and OMH, so that if somebody calls 911 in Schenectady County and they don't necessarily need law enforcement response, they will forward the calls to us and we will manage it. If law enforcement ends up out there, they call us and we meet them out there, and many times let them drive away. We do that in all of our counties. We're just not 100% built in to the other 911 systems. We're working towards that. We also work really closely with 988. 988 actually makes a lot of referrals directly to us because they are a call center. They are meant for more support, but when they start managing somebody that is actively suicidal or is, potentially a harm to themselves or others, they're actually involving us, and then we can respond on site. So just so you understand sort of if we show up, sometimes it's because law enforcement has also brought us, even though you may have called 911, or if you've called 988, we might end up ultimately being involved because we're the local service.
Great. We do have 2 questions here. Is there any age requirements for accessing mobile crisis? And then what's the time frame generally from the time like someone responds to the call and possibly if someone like needed to go out to someone?
So regarding age, really, it's, I guess the best way for me to say that is like, verbal on up, but it doesn't necessarily mean that, if we're talking about a 3-year-old and a parent is struggling, then we would be able to work with the family and safety plan with the family. So there really are no age restrictions. The area that it gets a little tricky in regards to ages, if we're talking maybe an elderly individual that has like an already diagnosis of Alzheimer's. That might be some of our questioning, because if somebody already has a medical diagnosis that isn't going to necessarily change some of their symptoms or behaviors, then it may not be appropriate to get us involved. But we actually get involved in those calls a lot because they tend to call law enforcement. So then we help navigate and getting folks connected to like adult protective services or working with the families. So there is no age requirement. If for some reason it's the situation is not something that maybe our level of care, then we would have that conversation with you and get you connected to the appropriate service. In regards to response, so that varies. I have 2 offices. I have one in Schenectady County, and one that is housed up in Queensbury. We cover 6 counties. So the Schenectady office tends to respond to lower half of Saratoga, Schenectady, Rensselaer, and Albany. And then the Queensbury location tends to respond to the other side of Saratoga, Warren, and Washington. It also can vary, like the phone rings between the both offices. So you might actually call and talk to somebody that's sitting in the Schenectady office, but they're dispatching a team that's out of Queensbury or vice versa. Response time varies on team availability. If we have a team in the moment, then it will be the amount of time it takes to get there. So for example, if you're in Queensbury and we have a team available in that exact moment and you're on the border of Vermont, we don't have lights and sirens, so it will take us the time that it gets there. So it could be up to an hour. We have up to an hour within our contract, really 3 hours in our contract to respond, which kind of seems weird if somebody's in crisis, right? So we really try to get there within an hour because most locations within our 6 counties are at least an hour from our office. Some are closer, obviously. If we don't have a team in that moment, we don't turn the call away, which is something that used to happen prior to me coming on board. We will say we don't have a team in the moment, that if you can keep that situation safe, we will send a team as soon as we do. So like if you're calling in Troy and now I have a team that's already out in Albany, as soon as they're done with that call, they'll go to the call in Troy as long as you keep it safe. So we get called by like schools a lot, schools, probation, families as well. And we'll say, like, if you can keep that individual safe, then, we'll let you know and we'll come as soon as we can. It won't be like, sorry, we can't come at all. If we don't have a team and we will never have a team, then we will let you know that as well. And we'll help problem solve. But it's never, we don't have a team unless we don't. And, or if you can't keep it safe, then we will help determine what the next level of care is for you.
Wonderful. Another question we have is just to clarify that it sounds like the standards for referral to the hospital is that the person is suicidal, they do have a plan, they have the means, and have no positive supports. Is that a correct kind of way of stating when you would refer someone to the hospital?
Those would be red flag indicators for me. It is not an absolute.
Okay.
For us, and again, those might be things that you can use just in your thought process of managing somebody, but I would ask you not to be making those decisions if you are not a licensed clinician. Because, just for an example, further down in our slides, we also have 2 crisis stabilization programs for youth for 5 to 17. And we have kids that stay with us, and it's a voluntary program. It's not a residential placement. They go there instead of going to the hospital, but they might actually have suicidal intent, but they don't necessarily have access to the means at that program. If somebody in the community is like, yes, I want to kill myself, but I don't know, whatever method they say they're going to use, they don't have access to, and it's not a reason that, like, there's no access at all, and we know there's no access, and there's no real intent, then we may still leave that person in the community. It really depends on their access and their intent, or if, again, they might be like, well, I might just run into traffic. Well, do you really have a plan to run into traffic? Have you really thought about that? So there's some other variables to it, but those are definitely things that we would be more cautious around if somebody had intent, plans, or means.
Okay.
But it's not an automatic, we would send that person to the hospital.
All right. I'm going to sneak a question in kind of with that too. So say hypothetical situation, staff are at the shelter, at a youth shelter, and they are working with a youth who is in crisis. Does the youth need to be willing to participate in the phone call with your agency to hear about, what options might be best, or can staff call and work with your team to kind of think about what may be the best scenario for that youth?
So if you have an individual that's at the shelter, or really anywhere, it gets a little more tricky when it's adults in their own home.
Mhm.
So we are technically a voluntary program. However, that means we voluntarily ask people to participate in our services without involving law enforcement. Because if we get a call for somebody, whether it's at a shelter or somebody's home, and we're told like that person is expressing suicidality, and we call them and say, hey, we'd like to come out and talk to you, and they say absolutely not, but we have enough information that we feel they are a safety risk to themselves, we are going to go with law enforcement, because we can't just trespass. But at a shelter, if you have say a 16-year-old that's expressing or acting in a certain way, or whatever the crisis might be, if you call us and give us the information and we're like, okay, that we feel like that's enough for us to come out, we're going to still come out and try to engage with that individual. And of course, if they do not engage with us, then we have to assess whether or not we feel we can still keep them in the community safely based on their symptoms and behaviors that we're seeing. Many times what my staff are trained to do is that, especially if it's somebody that's suicidal, and we've been told they are, but now they don't want to talk to us, they kind of are given that option, like, you can either talk to us and give us a reason to keep you in the community, or we're going to have to send you to the hospital because we don't have enough information to keep you in the community. So it kind of gives them sort of some choice on how they want to manage their next steps. But if we have enough information that supports, and we can't get them to safety plan with us, then we would be sending them to the hospital. If we get out there and it's because somebody might be acting strangely in the community, but they're not doing anything unsafe, and we're able to observe them, then we may not automatically send them to the hospital. But if it is a public location, that is not a private home, and you or whoever's calling would like us to come out and do an assessment, we try to get the individual to be open to it, but that doesn't mean we don't not go, even if they're not. It just gets tricky when it's a private residence. We can't just go knock at somebody's door, but also for safety reasons, we're screening for safety. So some of the questions that the shelter staff might hear from us is, are they currently acting out in any violent manner? Because if we feel like we need to go safely with police, then we will. But many times when we're dealing with agencies, they've already kind of decided they need that level of support anyways, or feel like they can manage it until we can get there.
Thank you. And one last question before we keep going is, if a client is not in crisis, but they may need outpatient services, should the agencies be working directly with the client to find the outpatient care, or would Northern Rivers be able to support that as well?
So I think at any time you have somebody that is in need of services and may not necessarily be in crisis, but potentially could be going into crisis, you could definitely call the crisis line and just explain that the person is not actively in a crisis and they don't necessarily need an evaluation, but you're looking for support on resources in the community. And then we would be able to connect the person calling either to our case manager or to one of our peer specialists or family advocates.
Fantastic. Thank you. And we'll keep going, but if people have more questions, feel free to keep them in the chat.
So just jumping to, kind of what we do in our assessments, we obviously look at what the current situation is, the source of the stress, their mental health history and symptoms. Protective factors are huge for us. That is really a lot of times what we decide and how we decide if somebody can be maintained in the community, especially for like adolescents. If they have a lot of positive supports and people that are willing to keep them safe or work with them on being safe, then we take that very seriously, as opposed to somebody that might have no supports, and not have anybody to turn to when they're feeling at their worst moment or having any thoughts to hurt themselves or others. Cultural considerations are a big piece of our assessment. Risk factors, and then obviously the piece about the risk assessment plan, intent, or means. Current functioning, we also assess. So a lot of times the thing that we've run into law enforcement, because they're trained in the academy, the only piece that they remember about a pickup order or 941 is that the person has to say they're suicidal or homicidal. And there's another piece to it. They have to be not being able to take care of themselves. But there's a fine line between like somebody saying like, oh, they haven't been eating. Well, what does that mean? Like only for a day, a couple hours? Has it been weeks and they've lost 50 pounds? Then, somebody not eating is subjective, or somebody not sleeping. A lot of times we'll hear like, oh, they haven't been sleeping. And I'll be like, okay, well, how many hours did they get last night? Well, they only got 5. Okay, well, that's still sleeping. That's, somebody that's not slept 0 hours in 4 days, that's not sleeping. So things like that we look at. And then again, we do a mental status exam if we're out on site, which looks at behaviors and symptoms, orientation, whether they're, cognitively able to even manage our questions, or even problem solve or safety plan with us. Many times for youth, we are safety planning not only with the youth, but also the supports involved. Adults, if they have supports, we are, but many times it's just with the adults. So again, we always either safety plan or send to the hospital. That's one or the other. There's nothing else in between for us. And we have the follow-up calls, and then we do our best, as long as the individual is open to it, is to connect. Now, we all live in the same world that services are extremely challenging to get. I don't have any special wands or exceptions, but what I can tell you is that somebody that has touched crisis services and has us advocating for them sometimes has a little bit more pull than just somebody making a phone call, to say, I want therapy. But we also, kind of keep up with, who's taking new clients, who isn't taking. We work really closely with the SPOA coordinators in each county, to kind of see if they can put any services in place. We're always looking at what is available. And I'm really excited because we haven't had actually case managers on our staff for a little bit now, and we've just introduced them back in. So I'm really excited about that, because that's been my focus in making sure that we also are really making sure that referrals are following through, and not just making a referral and kind of letting it sit there and not anything ever come of it. So When we safety plan, this is kind of what our safety plan looks like. Sometimes we'll do a verbal safety plan, but many times we want to, do a written one, but sometimes our clients, might be too paranoid to sign a form. So we might do a verbal with them. But that's what that'll look like if you are on site with them or with them, it's a triplicate form. So we will, hand the client and whoever else would like a copy. If we're doing it over the phone, we always ask if somebody wants it mailed to them, and we mail it to them. Because our telephonic is the same safety plan, it's just embedded in our system, and we will email a copy out to, or send out a copy to whoever wants it. I talked a little bit, the next slide is just about our dispatch. So I talked about that a little bit already, but this is just, to give you an idea of our call volume. So it's June to June because we started taking our own calls as of June 4, 2018. But just to show you the progression of our calls, these are total calls. So these could include something we managed over the phone, whether it be just support calls or safety, assessment calls, informational calls, referral calls and alerts. Sometimes, if you have somebody, that's maybe staying at one of your shelters and you're concerned that they might go into crisis, you can always even call us ahead and say, just to let you know, this person is struggling and, we may be calling you in a couple of hours, and just to kind of give us a heads up. But just to give you an idea of to date, up until yesterday, so from June 4th, 2022 till today, we are already at 6,783 calls. So I anticipate we're going to bypass that 75 call volume. It just continues to increase every year as people know about us. And again, that push to utilize our services. And even if we don't end up on site, we're a service for you to call to say, this is what's happening. What do you recommend we do? So that you at least just have that support. The next slide is really just our calls in general from June 18 to June 20. These are calls that the numbers don't add up from the previous screen, but that's because these are all of our calls that we managed from a safety side. So whether that was over the phone or in person. So this number, this 11,053, takes out alerts or informational calls or calls that got terminated. This is how many calls from June 2018 till last June that we managed, 11,053. And this is how many we sent to the hospital. So it just gives you a perspective. Like when we show that to law enforcement, they're like, seriously? Like we send people all day long to the hospital. I'm like, and that's why you're driving to Glens Falls, because they're, out of all 20 of those people you just drove to the hospital, one of them probably needed to go. And so we need to all work together to not inundate the systems. Because when individuals, like I'm sure you all saw recently on the news, Albany Med was in the news, somebody's loved one had to wait 20 hours or something like that to be seen medically. And that's because the ERs are filled with individuals that should be going to urgent cares for medical things, or should be going to their primary care doctors for medical needs, and or going to a mobile crisis for behavioral health initial assessment instead of going directly to the ER. So we're really trying to work together with everybody to break that pattern. I do a lot of trainings, like I said, with not only law enforcement, but primary care doctors, schools. We have a lot of different initiatives with probation. We worked with Columbia County. This is in Albany, Saratoga, and now it's going to be in Rensselaer County. That kids that are going in for their initial intake, they get screened by questions at Columbia, screened, and they initially plan to send all of those kids to the hospital that screened a level 1 or 2. And every single one of those kids, minus like 1 or 2, say there's been like 100 in the last several years, we have sent maybe 2 of them to the ER because they really didn't need to go to the hospital. They needed to be connected to services. We have a pathway for one of the jails that after somebody's been in lockup, they have a suicide screening. That one of the questions is like, are you embarrassed for being arrested? And most people say yes. And so that puts somebody on a suicide watch. And then all those people, when they're getting discharged by the judge back to the community, because now they just have to return to, with bail reform, all those individuals were being sent to the ERs instead of just getting an evaluation. So now we screen them and prevent all those folks that might have been in lockup for petty crimes to bigger crimes from having to get sent to the hospital because they might have said yes to one of the 10 questions. So a lot of initiatives out there. And like I said, one of our biggest feeders to our system definitely during the day is schools. We're in schools all day long. So one of the things that I did when I took over was break our teams up. So if we're going to a school or we're going to a setting that might already have professionals at it, we'll only send one clinician instead of two, so that we have more teams available. We even go into Samaritan Hospital and Albany Med. They consult with us to get kids out of the ER. So it's this vicious pattern that like these kids get brought to the ER and now we're getting called to go to the ERs to get them out when we could have just been called to go to where they were and saved all the dollars and Medicaid dollars or tax dollars for that ambulance ride and the police ride and all that to sit in the ER for hours to find out mobile crisis was just going to send you home anyways. So just things to think about in regards to the system and how it works.
Jennifer, we do have a question in the chat actually.
Yeah.
In your teams, how many teams do you have that respond for each office? Do you have one team at a time?
That varies day to day. We on an average day, if we're fully staffed on that day, we should have anywhere from 2 to 3 teams. Sometimes we have 4, sometimes we have less. It all really depends. We always keep 2 people on the phone, so there's always somebody answering it. So every day is different. I can tell you right now, my North office is a little lighter on staffing. I have some people out on medical leave, and I also am down some staff. But we are slowly increasing that staff. But it's not so much out of each office. So like if we have a call that, might be up in Upper Saratoga, and I know that the only team I'm going to have available is coming that I can send is from my Schenectady office. If that individual is safe and can be kept safe, we'd rather send somebody all the way up there instead of that person going to the hospital. So it really varies day to day. Days, sometimes we're more staffed than evenings, but then that sometimes is different. Like today, due to people being out sick or being off, I had only like 1 team out of each office. Whereas tomorrow I could have 4 teams out of each office. So it really varies based on the day. So,
thank you.
How can we?
All right. You want to share a little bit about the crisis residences?
I just see the one question in the ER. So I'm just, or not yet, one question in the ER. That's my brain is. I just spent 4 days at Albany Med, so my brain is still thinking ER. How can we train educators?
Training educators.
AP 20 years ago. What is AP?
Liz, if you want to unmute at all to
yeah, sorry
on your question.
Emotionally disturbed person.
Oh, okay, I know that part, but what about the as an AP?
Oh, assistant principal, right?
Oh,
it was our decision to call that ambulance, and I definitely resonate with the cost of sending that kid to the ER and nothing gets done, because they always did most of the time go home. But, we as educators, again, were very frustrated, and that was like a quick and fast option. And I can't believe it's still happening 20 years later. So how can we train educators, particularly administrators who do make those decisions?
So I do a lot of work. Like I just recently was up in Saratoga and met with, and forgive me, I don't remember what the name of the group was, but it did have a lot of educators at the table and principals. And I know that I'm planned to go back up, which we've done in the past, but to go back up to the, it's like the agency something that happens like at 7:30 in the morning, because educators apparently start their day at like really, really super early. But I've been doing a lot of work with trying to get them. Um, Sometimes I find that if we can get the support staff or the social work office or the nurses, I've done a lot of work recently. I did a presentation to the nurses had a convention, school nurses, and that really drove up a lot of conversation with some administrators on why they shouldn't just be directing folks to call 911 or call ambulance. Also do a lot of work with the resource officers in the schools, if there are resource officers. So I think over time you'll see a decrease, but I think that if you have particular school systems or districts that you see that that's still happening, I encourage you to direct them to me, to at least have a conversation with them. Let them know why that is not a good choice and that there is no magic. There's a lot of people that think the ER doors open and there's this magic that happens. It is actually an extremely stressful situation for families and individuals that are already dealing with trauma. And to sit there for hours and hours and hours to just get asked a few questions and sent home with nothing, it is frustrating for everybody and it's not helpful. There's no medications happening. Like a lot of people think that if you go to the ER, like they're going to change your medication or they're going to give you medication. ER doctors they are there for trauma. They're there to sew your body back up if you end up in a car accident. Like when I talk to primary care doctors, I say them all the time, like, if you send somebody to the ER, you're sending them to your equal, and actually not even your equal, because you do general medicine. You're now sending them to somebody that wants to help you if you've damaged your arm or broken your arm or, not something that you can do with the brain per
You're
se.
absolutely right. I have sat in the ER room with students, and it just for me, I'm retired, so it just blows my mind, and I'm involved in youth homeless, reducing youth homelessness.
Yep.
But like, it still boggles my mind that after all these years, 1 in 10, I mean, well, that, from hearing you say it's still an option. It shouldn't be an option at all. It should be the negative option, meaning that you've exhausted all avenues before you call 911. You know what I mean?
I absolutely agree. I think unfortunately we still live in a world, and I don't know how to get out of it until everybody realizes how we are a part of failing the system, is that we make decisions that not only make our system less user friendly for individuals that actually need it, but also it's not trauma informed for our clients. But it comes down to sometimes liability. And one of the things that, I at least use for law enforcement, where I still have this conversation with educators and, administrators all the time, that we have to understand that liability, like no matter what, we're liable. I mean, there are people that could tell us, that they're going to be safe and they might not be 3 days down the line, but in the moment they were safe. So we have to stop worrying about, getting sued, and instead just worry about the actual individual and how to help them in the moment. And when I get that magic wand, I will share it with everybody, because we need to be thinking about what is best for the individual and not, ourselves.
Yes. And just to share, I'm now involved in nonprofit, all that to say youth grants and sometimes county grants, they're now requiring youth development training, up to 6 hours of training, and trauma-informed person is one of them, which
Okay,
seeks
wonderful.
to assess yourself and then assess the situation.
That's wonderful. Yeah, I think it's really important. Like I said, I also recently got certified to train law enforcement and corrections in trauma informed care, just so that they even have a better understanding of when they're responding to calls and how to manage it. Because I think that we all have to start, like I said, understanding that everybody that we come across, even somebody in the grocery store, we have to assume that they have some level of trauma and understand how to navigate that and work with them and support them. I mean, not maybe everybody at the grocery store, but just as an example. But so just real quick to jump on to a little bit further, just for folks that are working with adolescents, we do have 2 crisis stabilization programs. Healy House is been around for a super long time, so some of you might be familiar with it already. It did change regulations a couple years ago when North Star opened. North Star actually was a pilot program and was the only one opened in New York State for this age level, but also successfully during COVID, which was challenging because every time somebody got COVID, we had to shut down and start over. But we're in a much better place now. But those are voluntary programs. Individuals can stay up to 21 days. That doesn't mean we necessarily keep them for 21 days. It is independent. We really look at each youth. I really don't like to keep kids out of school for long periods of time, if possible, but we look at what their needs are. But these are also programs to avoid unnecessary hospitalizations or emergency rooms. Sometimes everybody needs a break. It's not a respite program, but everybody gets respite while they're with us. Kind of everybody gets a break. If there's crises at home or if there's crisis at school, but it is a treatment program. They have treatment groups. But they have to be voluntary and willing to go there. We are not a locked facility. We do not have physician oversight. So we cannot do like PRN or stat medication, like an emergency room or crisis unit. We are not a restraint program, but we are a safe place for kids to come and work on whatever they're struggling with at the time. So that was what I was kind of referencing, that if somebody is suicidal or cutting or burning, as long as we can keep them safe, even if that's how they're still feeling, we will have them come to our program instead of having them go to the ER. Aggression as well, as long as we can maintain that safely. Sometimes aggression is specific to an individual at home, and just breaking up that cycle by coming to us sometimes helps support. It's a good way for us to evaluate behaviors, like if a family is struggling at bedtime, and then they come and stay with us and we are not having that struggle, kind of looking at what what it looks like at bedtime at home, or what other services might be needed that are already not in place or that they need. So anybody can make a referral to that program. It is you can either call mobile crisis and just say you're calling to make a referral to the crisis residences. There is a mini form that I did send out with all the other flyers to Bree, but families can call us directly, providers, really anybody can make those referrals. If a youth is on medication, we have to have physician orders to be able to give them their medication. And we do have some rules like, kids can't come with their phones because it is a treatment program. But it's not like hospital where they're locked up and that they can't leave until told. We would like them to come and work with us and work through their crisis instead of forcing them to.
Jennifer, I have a question I'm going to throw in here. There are times that youth are being discharged from shelter, or not sheltered, discharged from hospitals, yeah, and possibly leading to a shelter stay. Yeah. And sometimes the discharge from the hospital is stating that youth are still experiencing challenges, so it might be best that they not go back to the home just yet. Mm-hmm. But we often don't want youth to be experiencing homelessness just because of that. Yeah. Do you see that this program as something that people could refer to after a hospitalization, or is it really just a diversion from before?
No, we actually take referrals from emergency rooms, crisis units, and even inpatient stays. Okay. Sometimes kids aren't ready to go home per se. Maybe there's still some family work that needs to be done, but it doesn't warrant the level of an inpatient care. Mm-hmm. Or like I said, if somebody is in the crisis unit or emergency room that is still feeling suicidal and the families are like, well, we're not comfortable taking them home, then they will make referrals to us. They just have to have a plan. Like there has to be, if they come to us, they can't already be homeless because we're not a residential placement. We have to have a guardian in place for like emergencies, like their medical emergencies, or if for some reason they no longer could stay safe and we had to send them to the hospital or just discharge them, even if they didn't necessarily meet the criteria for hospital, maybe they wanted to run away or they don't want to follow our rules, we need a parent to sign on consents and be available to come at discharge or go to the hospital if we have to send somebody to the hospital, because we have no guardianship over these youth. They're with us voluntarily, just like at a shelter.
Got it. Thank you very much. That's very helpful.
Yeah.
And I think I'm going to throw one more question in. Some of our providers do serve all the way up from like 18 to 24. Do local like SPOAs or other programs have types of diversion for a little bit older or like short-term crisis beds through like the county?
There's more to come on that. Albany County through RSS has what I would call an adult version of our programs. It is called CDSS. It also requires somebody to have a home, but that's been around for a little bit. I think they only have 2 beds. Don't quote me on that because I haven't been involved in that care. But RSS does run a program like that. There are been RFPs out recently, and you will start to see crisis stabilization centers popping up. Like Unity House is getting ready to open an adult crisis residence. I don't think they should be probably open up by fall, but they are going to be another adult resource for like a similar to the North Star and Healy. And then there's going to be, like I said, these crisis stabilization centers that are kind of a deterrent from going to the ER crisis unit, but they are only for literally like 23 hours and however many minutes it is to get to the 24 hours. My brain just stopped, but those are to kind of give somebody like law enforcement dropping somebody off that might automatically be getting discharged from the ER that didn't need to be there, but in the moment needed some type of support. Those will be popping up across the state. I know RSS and Northern Rivers has potentially might be opening one up in the next year for adults and kids for that. But you're going to start to see a lot more crisis programs and things available over the next couple of years, because the state is really starting to put their money and resources into crisis services. Unfortunately, as humans, we live in crisis. I use the example that somebody says, oh, take your antibiotic for 10 days, and the minute we all start feeling better, we stop taking our antibiotic. And so this is what happens when people are on medications or in treatment. They start to feel better, and that's why they're finding that crisis services is a high need for even just support after I think what the world has handed us over the last couple of years. Just day to day living is hard. People don't get paid enough to afford groceries or pay their heat or their electricity, or even have homes to, keep their families together. So there's just a lot of need out there when it comes to like crisis situations. So,
yeah. We have another question in the chat. When being discharged from short-term crisis, do you have discharge meetings with the patients and their families?
For our programs, yes, we do, unless it's an automatic, unless it's like a last, unexpected discharge. If it's an unexpected discharge, sometimes, depending on when they happen, there may not be an ability to do that. But if it is a planned discharge, there is a discharge meeting that reviews the crisis plan for going home, any referrals that were made. And part of the stay is talking discharge all the time and what is needed to make it successful. If like at 9 o'clock on a Friday night, a youth is like, I'm not staying, then unfortunately in that situation, the family's just asked to come get them. There isn't the clinicians aren't there to necessarily do that formal discharge plan. So.
Thank you. Great.
So just in regards to Northern Rivers in general, we have outpatient clinics, we have school-based clinics. So there's clinicians right in schools across the counties that provide services that make it a little user-friendly for families that might not be able to get to services, but also it's integrated right into the school day. They have a youth and adult act. So We just started a Youth ACT program, which is assertive community treatment. For anybody that is not aware of that, it's a really, it's like the highest level of treatment you can have, you know, regarding like they go out to your home, they go to you. It's a team of a physician, nurse practitioner, a peer specialist, the clinician, and sees you a couple times a week. Warren and Washington County has their adult team with Saratoga County. Albany County has always had the ACT team. And Schenectady has it through Mohawk Opportunities. But the Youth ACT is something very new. Northern Rivers just probably within the last 6 months started the one in Saratoga, Rensselaer, and Albany. And then they're just going to be opening up in the next couple of months, one up in Saratoga, Warren, and Washington. And those are going to be the more harder to reach youth that seem to be in and out of hospitals. Because, you know, a lot of residential beds like RTFs and RTCs have shut down. And so we're challenged with really trying to maintain kids in the community, because that's really what is the best level of care for them, but with that more added service.
Are those services, the ACT services, available for those in shelter or on the street, or how are individuals being served by the ACT team?
So that adult ACT, I don't think it matters whether they're homeless or not. I don't know that it matters for the youth either. I think, you know, I don't want to 100% answer that, because the youth, well, both youth and adult go through SPOA. So I don't know what the expectation is in regards to for the youth on whether the family needs to be involved. That I don't know for sure. I know for adults, they service individuals homeless all the time. For youth, I can't imagine that they wouldn't, but I think that part of the idea would be around having the family involved, even if they're not necessarily living with them. But that I could find out more and let you know.
Thank you. And then there's also just one more question regarding the Healy House in North Star. If someone is staying there, is there a way to contact the individual other than using like the initial intake numbers and fax?
Yeah, so we have a direct line through to the programs and to the youth, but we only provide that to the like whoever the guardian is. And then the guardian facilitates an approved list of who the youth can call out to or accept calls from. Because we don't really have any way to monitor if they're speaking to somebody that may be not safe for them. So we deter to the family on who they can and cannot speak to. But yes. And while they're with us, the piece I probably forgot to mention was we're a little different than the hospital. If they're already in treatment, we don't stop their treatment. We actually maintain their treatment. So if they have an appointment with their physician or they have an appointment with their therapist, they still participate in that. We don't cancel it like if they're like in the hospital.
Thank you.
Some other just areas, obviously, we have health, home care management. We have adoption and foster care, education, residential, and then our SATRI training facility offers trainings to the community as well as all the staff here. So they have a tremendous amount of trainings, but if you go on our website, and they are from like, you know, things from like mental health first aid to Talk Save Lives, Safe Talk Assist, which is applied suicide intervention skills. They do suicide trainings. They do just trainings on working with adults, working with personality disorders, working with autism. So if you're ever looking for additional trainings, you know, whether it'd be for continued education or just in general, to work with the folks, I highly encourage you look at that. These are some of the ones that I would recommend if you're working with individuals that struggle with suicidality. And NAMI offers a lot of these, or Mahaney's offers these a lot of times. So they are out there. If you go on OMH, they usually list when they're offering these. But these are really good trainings to take, to have kind of as a tool. Also, if you go on to SAMHSA's website, they have a tremendous amount of tools and things you can utilize just to have in your back pocket. There's a lot out there that that can help provide you support. And I'm always available if anybody has any questions, or if internally anybody finds that their actual agency could benefit from me doing a training, or talking to those administrators. Just let me know. I do trainings all the time, whether it's in schools or in the community. I prefer to do them in person, but this didn't go as badly as I was worried about. I told Nancy yesterday, I was like, I'm stressing out. I'm like, I love training. I'm like, but this is so stressful doing it through the Zoom. So, any other questions, comments? I have thick skin, so if you've ever had a bad experience with mobile, I would ask you to make sure that I'm aware of that and to let me know. Sometimes we get information from families or clients, and it may not be exactly what happened, or sometimes it is, and that's how I can make things better, or train my staff better, or even just make us a better service. We are faced with workforce crisis like everybody sometimes. But I am always looking to improve our services, or address anything that did not go well. And so if you have had a bad experience, I'd rather you reach out to me and have that conversation so that you will use us again, rather than just not ever using us. Because I have individuals I come across, it's like, oh, I don't call you guys because you never have teams. But they're referencing from 10 years ago when they might have had one team across 6 counties. So just little things like that. I just encourage you to share our information, give our number out to clients. They can call us directly. It doesn't have to be you. And anything we can do to support all of you.
Jennifer, I am going to ask a question. If there are people outside of county, are there other agencies that serve this role like you guys, maybe in other areas? And would there be websites or areas that people could look to try to identify resources that serve like yours, maybe out in their area?
Yeah, so Columbia and Greene have their, I think they call themselves the MCAT team. They have their MCAT, they call themselves, that's what it is, MCAT. They have a mobile crisis team. All the mobile crisis teams in New York State that are actually active do all run a little differently, and many of them still do have gatekeepers. Like Albany County Mobile Crisis, you still reach them through calling CDPC, but they have an adult team. They have a team that's out in the hill towns now that also, we share Albany County. So we only do kids in Albany County. We do adults and kids in the other 5 counties. But Columbia Greene has one. The neighborhood center, which is out in like Schoharie, Herkimer, and all of that way, they cover crisis services, and they're called the neighborhood center. I'm trying to think. I mean, every county has some type of crisis service. It's just whether or not they're actually mobile, or not. But if you go to Office of Mental Health or even any county mental health aid website, they should be listing their crisis services. Or if you even go to the 988 website at this point, they have really tried to look at what resources are in the local areas. Because if you call 988 right now, not everybody knows this, but if you call 988 and say your area code happens to be 516, you're not actually getting a 988 call center in the Albany area. You're getting the call center that's down in Long Island. Or if you just moved from California, you're now getting the 988 call center in California. It has something to do with phone telecommunications stuff. They haven't been able to work through that. That's through the FCC and stuff. So just things like that to keep in mind, that for our local centers, which is actually housed out of Syracuse, I've worked really closely with them to make sure they know what our services are in our 6 counties. But not everybody understands that when you're calling 988, it could be somebody in California, depending on what your phone area code is.
Yeah. Thank you very much.
You're welcome.
We'll leave it open too if there are any further questions, but I think one of the most important things is a huge thank you, Jennifer, for your time
Yeah.
today to share with us. It really means a lot for all the conversations we've been having. And I think the nice thing that we're hearing as well is whether it's a crisis, whether a youth is really just coming in and we're discovering what they're going through. It sounds like Northern Rivers services are available for all of these agencies to call, whether you can get the exact service or be referred to community ones. We appreciate you being a part of this system to support youth, Jennifer. It means a lot.
Absolutely.
All right. And I will pop up on the screen my email. I will make sure after this, we did record the training, and Jennifer and her team supported us with their referrals and with some of their marketing materials. So I will send that out to all of the attendees that are on this call today. But we are very excited to have everyone join us today. So if others would like to continue to join the Regional Advisory Board on Youth Homelessness, you can email me and I will throw up my email right here for all of you guys. But I want to say thank you all for joining us today, and we really appreciate you taking the time.
And thank you so much, Bree. What a fantastic presentation. And what a great turnout, for real.
Yes, very excited. Thank you, everybody.
Well,